Legionnaires' disease, pathophysiology explained. What causes Legionnaires' disease? Legionella pneumophila is an aerobic, gram-negative bacillus, and the primary cause of Legionnaires' disease, an atypical, often severe form of pneumonia. It thrives in freshwater and man-made systems like cooling towers and hospital plumbing, replicating inside free-living protozoa. These protozoa act as reservoirs, protecting the bacterium from environmental stressors such as chlorine. Entry and transmission. Infection occurs when people inhale aerosolized Legionella from contaminated water droplets. Once inhaled, the bacteria reach the alveoli and are phagocytosed by alveolar macrophages, cells that resemble the environmental protozoa. They typically infect. CDC +1. Intracellular hijacking. Inside macrophages, Legionella uses a specialized secretion system /ICM type for secretion to prevent the fusion of the phagosome with lysosomes, avoiding degradation. Instead, the bacteria modifies the vacuole, called the Legionella-containing vacuole LCV, into a replicative niche by recruiting endoplasmic reticulum vesicles and hijacking host lipids like cholesterol for its membrane. With these resources, the bacteria proliferate within the LCV. Once nutrients are exhausted, they switch to a transmissive form, lyse the host cell, and infect neighboring macrophages, spreading the infection throughout lung tissue. Host immune response and inflammation. The intracellular replication leads to cell death and release of bacteria into the lung interstitium. Infected macrophages provoke a robust inflammatory response. Neutrophils and monocytes are recruited, releasing enzymes and reactive species that cause destructive alveolar inflammation and damage to lung tissue. Effective control of the infection depends heavily on cell-mediated immunity. Activated macrophages and T cells limit the bacterial load. Humoral antibody responses play a less critical role in controlling intracellular growth. Clinical manifestations and systemic effects. Legionnaires' disease manifests primarily as severe pneumonia, often with high unrelenting fever, dry cough, shortness of breath, and systemic symptoms such as confusion, diarrhea, or muscle pain. Its incubation ranges from 2 to 14 days, occasionally up to 20 days in rare cases. Radiologically, the pneumonia often presents with patchy, fluffy, or unilobar infiltrates, with a tendency to consolidate into denser areas. Sputum may be minimal, and pleuritic chest pain or effusion is less common than in typical bacterial pneumonia. Lab findings often include hyponatremia, evidence of acute kidney injury, elevated inflammatory markers, ESR, CRP, and sometimes liver enzyme elevations. Virulence mechanisms. Key virulence factors include a uniquely hydrophobic lipopolysaccharide, LPS, which helps evade host immune detection and inhibits phagosome-lysosome fusion. Type 4 pili and flagella, aiding in adhesion, motility, and invasion of host cells. The /ICM system that delivers effector proteins, modulates host cell trafficking, and prevents intracellular digestion of Legionella. Manipulation of host cell proteasomal pathways to generate amino acids and lipids necessary for bacterial growth within vacuoles. Outcomes and severity. Untreated cases can lead to complications such as respiratory failure, acute kidney injury, shock, neurological deficits, or even multi-organ failure. Mortality ranges from 7% to 25%, with higher rates up to 50% in immunocompromised or hospital-acquired cases. Conclusion. Legionnaires' disease is a serious intramacrophage infection driven by Legionella pneumophila's sophisticated ability to hijack host cells, replicate within alveolar macrophages, and provoke destructive inflammation. Understanding its pathophysiology is essential for accurate diagnosis, timely treatment with intracellular penetrating antibiotics, and effective prevention strategies that target environmental reservoirs. Stay tuned for all news on Current World News.